Welcome to our video series on phacoemulsification for beginner surgeons. The first thing to do when you start is select the right patient who will be cooperative during surgery. Educated guesses can be made using the light of the slit lamp or IDEO. We begin with incision creation. We are using a double blade technique to stabilize the globe with side port and main wound created simultaneously. A limbs forceps can be used, but it is traumatic. Cotton bud may also be used. It is important that you do not touch the iris to prevent pain sensations and inflammation. When instilling a dye to stain the anterior capsule, explain that there will be a lights out movement. Wash the dye, inject viscoelastic and start the rhexis. Ask the patient to look at the light continuously. One-handed rhexis can be done if the patient is cooperative. If not, a closed McPherson or any smooth atraumatic spatula can be used to stabilize the globe. Here, a Haldipurkar's forceps is being used for rhexis. You may use a cystotome as per your comfort. After completion of the CCC, the cortex and capsule are separated by hydrodissection. Hydrodelineation is then performed with fluid injected into the body of the lens to separate epinucleus from nuclear mass. Golden ring sign is seen, which means that hydrodelineation is complete and we can safely make attempts to rotate the nucleus. If it rotates freely, we can proceed with phaco. We are using a ballpoint chopper in the non-dominant hand and following wedge and chop technique, where the nucleus is mechanically fractured between the phaco probe. The chopper should go beyond the equator, behind the nucleus, while the phaco probe is embedded in the central body of the nucleus, and then we proceed with mechanical fracture. This can be done multiple times proportionate to the hardness of the cataract, maybe just twice in a soft cataract or even 8 times in a hard cataract. The rationale is that creating multiple pieces helps to emulsify them quickly without endothelial damage. The ballpoint chopper can also be used to remove and separate a sticky epinuclear sheet. If there is a PCO, it can be used to mechanically rub and remove it. If you are well versed with phaco under retro or peribulbar block, shifting to topical is a journey that can be sailed with self-confidence and regular practice. Many surgeons are hesitant to operate without block, but this is rather a mental block that you can overcome. It is important that you talk to the patient during surgery. Everything that they see and experience should be explained to them, such as sensations of pressure, cold water, and the different lights they see. If not a local anesthesia, give them a vocal anesthesia. A second side port can be made now as shown in the video if you are using bimanual irrigation aspiration. If made earlier during the surgery, it may leak. In the beginning of the surgery, the patient sees lights with ill-defined borders which become brighter and larger after IA like a pincushion. Before you implant the IOL, explain to the patient that the light may not be visible for some time as you shift the microscope to prepare the cartridge and injector. Now you can see a PCO at the end of irrigation and aspiration, and it is being cleaned using cap-vac mode, which is very safe. In this mode, it can be approached without risk of damage to or catching the PC. We are using hydroimplantation technique to insert the IOL where the irrigation probe maintains the globe. Patient must be told to focus on the light, and while implanting the IOL, you may explain that he can see colors like that of a kaleidoscope and the 4 lights of the microscope. If IOL has been implanted under visco, please remember to wash it at the end of surgery. Corneal wound and port hydration can be done without increasing pressure inside the eye by misdirected fluid. Hydration should only be done in corneal layers. Always thank your patient at the end of surgery for their patience and cooperation.